Hello, everybody. This is Adam Rindy, and we're just about to get started. People are filing in. We have over 125 people signed up, and let's see. I think because we're already past time, I think I'll just get started. And I did get a number of questions for me to cover during the presentation, and I think I've weaved most of them in, and we'll talk about how we can cover additional questions towards the end of the presentation. So without further ado, we'll get started. So this is what we'll be covering today. A lot of people requested that I focus on workup and assessment and treatment primarily, and a lot of people did not request too much background information on SIBO. Now that's fine. The only thing I will say is that even though about 80% of the attendees are healthcare providers, some are healthcare enthusiasts and people dealing with health issues related to this, and so there might be a bit of talking over some folks and might be moving too fast forward, but you'll have the presentation if we need to if you need to review that. Anything that we've moved over too quickly. This is the third time I've given this presentation, so it's just amazing how much it's evolved since the first one, and it's getting more and more complex. So bear with me as we work through some of this today. Most of you know me or know about me, so I'm not going to belabor my background here, but this is in case you're interested or we've never met. And I just want to quickly acknowledge some of the pioneers in the SIBO, small intestinal bacterial overgrowth research and clinical practice. Many of these folks have personally helped me understand how to treat this and address it and how to heal the gut, and very thankful for these folks here. It's very important to have just a quick comment on the context of when dealing with gastrointestinal disorders. The thing I like to show is that the gastrointestinal tract is interconnected with so many systems of the body that we must not lose grasp of that, and especially the mind-gut interface is something that is really being studied, and this quote is quite remarkable since it dates back to 1858, and talking about laughter and how laughing during eating or during meals was considered great medicine to digestion, and it just makes so much sense that I wonder how much of the stuff we're talking about today would be drastically improved if we had sort of this type of atmosphere and joy around food, and while we eat and while we digest our food, how our nervous system was responding. And just a little, on that note, a little cartoon here. And most naturopaths are experts in stool analysis, and after this presentation, we're going to be probably experts in flatulence analysis, and our parents must be so proud of us. Okay, this I'm going to actually maybe refer to later, but I just want to quickly mention someone who really taught me how to deal with these complex health conditions, and this is really an important point, is that Emergence theory is when we follow the patient's patterns to guide us, and instead of us necessarily guiding the patient, and we follow the symptoms and the shifts and the patterns to help us understand the complexity and web of the problem. This is really relevant in SIBO because the gut shifts in many different directions, and if you're able to be sensitive to that and watch these shifts, you could really help a lot of people. Okay, so here's the definition of small intestinal bacterial overgrowth. This is an evolving definition, and one of the things that I want to point out is that it's primarily discussed as a secondary disorder to other conditions that might be leading to bacterial overgrowth. And this bacterial overgrowth is in the small intestine, where bacteria is migrating there, so that it's ending up in locations where it should normally be sterile. And so this bacteria causes fermentation, inflammation, and malabsorption issues. Now, this is primarily a secondary disorder, but sometimes it is a primary disorder in something called short bowel syndrome, also blind loop syndrome, which is sort of the first earliest reference to bacterial overgrowth was related to this. The other comment I would want to mention is that usually the underlying etiology or underlying cause of SIBO is related to changes in anatomy or changes in motility, malabsorption, or hypochlorhydria. So these are the things I want you to kind of realize, that there's a lot of problems or concerns or confusions around SIBO, and some of the things that we'll be really hopefully getting into is that testing is really difficult and unreliable. SIBO mimics a lot of other things, so how do you know which one it, how do we know that we are actually treating the right condition? And there's a high rate of relapse, and I think we're also only scratching the surface. Is it a symptom of something bigger in the gut microbiome, or is it the cause of some of these other issues? So, but I will say this, when it does work, it can be life-changing to our patients, and quite rewarding as a practitioner to see something so problematic resolve with some simple therapies. Okay, so we're going to jump into clinical findings of SIBO, and the history taking, some of the things that would show up is this presence of postprandial bloating and distension. That's a key one, and you must have absence of red flags, so we want to make sure we're ruling out the big scary things. And by the way, these little symbols that are, it's a pearl in a shell, just to remind you that some of these things are key. So one of the key things to see when you're taking history is asking if the symptoms are worse as the day progresses. So as eating, does the symptoms get worse, and does fasting generally alleviate it? And also, one of the things that might be present is that it's abdominal discomfort, but it's not necessarily pain, is something that's commonly seen. Also, the patients may have a cluster of other symptoms like fatigue, joint pain, brain fog, myalgias, and this is a clue that perhaps there's some leakiness of the gut going on here, so it's more of a systemic problem. So again, bloating and distension is key. I think this is the unifying feature that I look for in practice, not only as a diagnostic clue, but also a clue as to how we're doing. So bloating is a feeling of a balloon being inflated in the abdomen, and distension is more of a visible thing where there's just an increased amount of girth. In SIBO, generally this sensation waxes and wanes. I'd say investigate other things if it's just constant. I ask, does the waistline feel tighter as the day progresses? That's a clue, and a lot of people will just nod their head and say, yeah, that's exactly what happens. So physical exam in our setting, in a naturopathic office outpatient setting, is relatively unremarkable. But in real severe cases of SIBO, we might see some of these things listed here. Also, rosacea does seem to overlap. So you can see that visibly, again, pointing to maybe a leakiness of the gut is affecting other systems of the body. Okay, physical exam. Here's our favorite word, which I knew I wasn't going to be able to pronounce, but I always botch that word. But what it means, borborygmus, is a sound that's usually auscultated or heard on physical exam. That's high-pitched, rumbling, gassy sounds that are excessive, and sometimes you can just hear them with the visible. Without a stethoscope, you can just hear them when the patient's sitting in the room or lying on the table. Also, on physical exam, you can do something called the intestinal secession splash, which is I really don't think is very practical, but you can see some examples of that on YouTube. But there's it's essentially you're rocking the patient's abdomen, pelvis area, and you're listening for splashing sounds. That's a feature generally of malabsorption. So here are some of the causes and underlying predisposing factors that would set someone up to have gut motility issues and maldigestive issues. So celiac disease is a malabsorptive problem that can lead to SIBO. All of these have been linked to SIBO comorbidities that I'm listing here, like going down the list. You can see that a number of these listed here have issues with gut motility or constipation or maldigestion. When you see this overlap, we're seeing in the literature that we can help patients with that are dealing with some of these other conditions by addressing bacterial overgrowth. And this is sort of an exciting new area for us. Again, more conditions of malabsorption. Diabetes and chronic kidney disease tend to have neuropathic problems with digestion where the motility is thrown off, and they may also have SIBO. There's sort of a controversial correlation with proton pump inhibitors. Some say that they do put you at risk for SIBO, and others say they don't. Also realize that any ileocecal valve problem is often a risk factor for bacterial overgrowth. These are some of the things I think about when I think about risk factors. Sort of the carbohydrate malabsorption, low stomach acid, low secretory IgA, which is an immune property that lines the gut. Opioid use comes up a lot periodically, as well as benzodiazepine use. They tend to be constipating, and some might put someone at risk for SIBO. And then any type of post-infectious scenario where there's a acute gastroenteritis leading into sequelae of digestive problems may make sense to investigate. Just a few more things here. As you can see, the list is exhaustive with the things that are being linked to SIBO. So I always get suspicious when I start to see the list add up. So what are we missing? What can we tie together? But I do think and there's data coming out where when we do treat SIBO in some of these conditions that there's improvement. It's not real solid yet, but that's an area of great research. So this is sort of the underlying unifying theory, is that in SIBO, that like we talked about, the bacteria is getting to places where it shouldn't. Then there's another element that there's some fermentation of poorly digested carbohydrates in the upper intestine, leading to gas production and malabsorption. And there's this third component, which is we'll talk about later, is the impairment of something called the migrating motor complex, which is a interdigestive process, meaning that it does not have to do with peristalsis but it has to do with what happens to the gut when we're not pushing food through the intestines. It's a cleansing wave, and this is what clears the gut, and it only happens generally in a fasting state. When there's impairment here, we tend to see SIBO develop, and when we address it, it seems to lessen SIBO. So this is just an indication that we shouldn't have much bacteria in the small intestine. It should all be towards the colon. The cecum, which is the connection between the small intestine and the colon, tends to be an area of sort of a crossover between bacteria, but generally it should be sterile. Quickly here, I want to talk about gas production by the microbiota. So this is really important to just kind of hone in on. There's two main gas productions, hydrogen and methane. So methane we'll be talking about a lot, and it's actually now being linked to the kingdom Archaea. So it's not really bacteria that produces the methane. They're a distinct group, and so we really don't really know that much about how to treat it. It's sort of not really solid yet. We do know quite a bit and see better results treating the hydrogen production. The hydrogen production is generally associated with when it's overly produced, when there's a large amount of bacteria producing hydrogen. We generally see associated with diarrhea, this SIBO that's associated with diarrhea, and the methane is generally a constipation. Methane to me is the real big area in this whole thing with a lot of questions. I see a lot of SIBO-like patients with constipation, more so in my practice than diarrhea. And we don't have a whole lot of good data about how to generally treat this. So this is going to be an important thing. So one interesting thing is that in this particular paper, they talk about how some of this gas is toxic or harmful to the colon. In fact, methane has been shown some weak links to, with overproduction, can damage the colon. There's been some links to colon cancer with methane production. Also interesting enough that methane can reduce serotonin, and obviously both of these off-gassing will affect the transit and motility and signaling. It seems to be a two-way communication between the central nervous system and the gut, and a whole host of factors, but we're seeing that these gases throw things off, and especially if they're overgrown in the small intestine. So the Human Microbiome Project is sort of the big thing these days, and probably next year this presentation is going to be so much more in depth about this sequence of communication that we're talking about. But This is a funny cartoon because it just shows how much bacteria are in the gut, and I just think it's funny because this bacteria is saying, "You call this living?" And it's quite indicative of really how outpopulated we are by bacteria. It's much more bacteria in our body and living on us than our human cells. So the other thing I want to just point out is the carbohydrate issue related to SIBO. So fructose, fructans, lactose, galactans, and polyols. These are all simple carbohydrates. They're not complex carbohydrates. They're simple carbohydrates that really have a tough time being absorbed and require good gut function to not cause problems. For example, like galactans really aren't absorbed. Fructose is generally passively absorbed. Lactose requires quite a bit of help from our enzyme process. Polyols are generally poorly absorbed. All of these add up in someone that has SIBO. If the SIBO, if carbohydrate intake meets a population of bacteria, and all of these components of carbohydrates are rapidly fermented, you can see gas production, luminal distension, which also increases osmosis in the lumen of the gut, which will increase water delivery to the gut. So the end result of this unique scenario is motility changes, bloating, pain, and discomfort. Now, if the gut is sterile, then this is less likely to be an issue. This is the foundation of why we use FODMAPs, a low FODMAP approach in treating SIBO. So normally when we're digesting carbohydrates, in the top slice of the slide, normally we'll see something like rice get into the distal part of the intestine, the ileum, and be digested and absorbed with little off-gassing. And then poorly digested starch will get down towards the ileum, start off-gassing a little bit, but then in the colon most of the gas is released. However, in small intestinal bacterial overgrowth, all this action moves up the intestine, so moves more proximal, not distal. And we see this off-gassing, and I've already talked about what happens when gas is created. So something like beans that has a lot of FODMAP, high FODMAP content will be off-gassed and cause motility changes, likely potentially other consequences, which we'll allude to later. This is just a quick thing. I'm going to talk about the interwave process. Interdigestive period is called the migrating motor complex. I already talked about this, but I just want to point out that this is a therapeutic target in SIBO that we have to address. This wave generally happens in a fasting state, and it's called the house cleaning of the lumen. Just flushes things out. If it's intercepted or blocked, or sometimes we think if people are grazing all day long, when does this happen? Well, it happens probably at night, but what's happening during the day if there's no break between eating? So it needs a good break between food to activate. And these are things that keep the small intestine sterile, which is obviously if the small intestine was relatively sterile, we probably wouldn't even be having this conversation today. These are situations where low stomach acid, backing up with constipation, ileocecal valve problems, anything that's along this line is disrupted, we could get an insterile environment in the small intestine. Exciting but also concerning is the histopathologic features that are showing up in biopsies of SIBO patients. We have now seen that It sort of looks like a small scale of what we see with celiac disease, where you have the villi changing form, and then in some patients, inflammation is moving into the regions close to the mucosal surface. I don't want to jump and say this means that we have leaky gut, but this is kind of what, with real intense SIBO and malabsorption taking place, this may be maybe where the research is going. And I did have a conversation with one of the top researchers, and this is something that's really being looked at with SIBO. So if we're not removing the trigger, there may be some more substantial impact from this setup of inflammation in the gut, where it might be affecting the body in more expansive ways, and in all the ways that we think about with leaky gut. And they're actually already seeing some signs that non-alcoholic fatty liver disease has some features of coming from the gut bacteria that's causing inflammation in the liver. I'm not going to talk too much about this, but this is sort of the book that set off a lot of what turned people on to addressing SIBO, Dr. Pimentel. It's thought that SIBO is one of the underlying causes of IBS, and the data is all over the place, but the most conservative data says that 37.5% of sufferers of IBS that meet Rome 3 criteria could be confirmed by the gold standard duodenal aspirate testing that they have SIBO. This is a really useful tool the Rome Foundation put out. This is a algorithm that would make sure that if you're working someone up for this SIBO, that you are covering your bases exhaustively and not missing any big things. Also, if you go to the website for this, which I have on the next slide, each of these steps is interactive and is explained, and it walks you through a nice flow sheet to find out where there's potential tests to run or potential red flags to consider. The big things, obviously, we don't want to overlook in any digestive problems, things that are plastic, cancers, also inflammatory bowel diseases. These things require much more management than something like SIBO or IBS. So alarm features and knowing those and walking through this process is really judicious and a good way to practice. And there's this link on the romecriteria.org website. It's kind of fun to go through and also educational. So basically, we get to this point again. Bloating is sort of the unifying feature between IBS and SIBO. IBS looks a lot of different ways, again, getting to the complexity. And so we're just really learning more and more about this condition and all the different elements to it. There's tests coming out that that are trying to prove that it's an inflammatory disease of the gut, and we do know that there's a huge mind-gut connection as well. So SIBO looks a lot like this in a lot of situations, so they do overlap. There's just a ton of costs associated with this digestive problem. I don't want to go into this too much, but just think about this when you're worrying about cost that it's taking. If you're able to solve or help a patient resolve IBS, it saves them and the healthcare system a lot of money and frustration and pain and suffering. So if you're on the right track, it could be a very worthwhile investment of expenditures. These are all the things that look like SIBO. I did already talk about a bunch of these things, but there's some tricky things that we think about as naturopaths that sort of overlap and make it complicated, like Candida and also celiac disease and things that we think about more parasitic infections. So it does take some clinical acumen to sort of narrow things down, and sometimes we have to expand our workup a little bit more than we typically would see. And here is my workup that I've sort of has evolved, and the research changes. So like the last time I did this, I wouldn't even think about doing glucose hydrogen breath test, but now I'm convinced that it has a useful application, and I see the limitations of the lactulose breath test. So let me just walk you through this real briefly. So on the left side is the blood work, and you want to consider doing all these things to measure the severity of your patient's presentation, and also to track progress. If there is blatant signs of malabsorption in the blood work or deficiencies, then you will need to track this patient more closely. Sometimes it's more subclinical, where their blood work looks normal, but say their breath test comes back positive. Then the stool test is good to make sure that you are also tracking for anything related to inflammation in the digestive tract, such as infection or lactoferrin showing any sort of indication of any type of inflammatory bowel disease, and fecal fat for malabsorption. On the right side, we'll spend a lot of time talking about the breath test. I do want to point out that sometimes it is useful to also test for fructose and lactose intolerance through breath tests. Imaging is generally not indicated unless you're really not making any progress, or you obviously see some red flags, or you're suspecting an anatomical cause. The thing that I will say is that there is sometimes an overlap between microscopic colitis and SIBO. I have seen this on occasion, and sometimes it makes it really tricky. There is research that says that the two are linked, where SIBO may lead to microscopic colitis. Sometimes, obviously if there's blood in the stool, imaging is indicated, and there will be times where you will not be making progress, or there are other features that reveal themselves that would require imaging. So testing for SIBO, the gold standard is jejunal aspirate. Nobody does it clinically because it's too expensive and too invasive, and they're not even sure what they're culturing so much, but it is used in research to prove some of the modalities are working or some of the tests are working. The most common thing that's done for testing for SIBO is the lactulose glucose hydrogen breath test. This is the company that is sort of well known for it is Quintron. So when you order, you can order this either inpatient, outpatient at different laboratories, or you can send someone to gastroenterology clinics. You just want to check which ones are in your area have the analyzer, or people can get the kits and take the test at home. And I would just make sure that they're checking and seeing if insurance is covering it beforehand, and all those important questions. So here's the basic philosophy, is that the glucose breath test, glucose is absorbed in the upper intestine, so it will be completely absorbed, and so if you see a spike, it's usually hydrogen. It only tests for hydrogen-producing bugs. So in a setting of constipation, I'm not sure how useful it is, but generally if someone has diarrhea, which is more likely to produce hydrogen, the glucose test seems to be somewhat accurate, because it takes out some of these other factors that we'll talk about later. Lactulose is absorbed and further down, and so you generally see a spike somewhere in bacterial overgrowth, you can see a spike of both methanogens and hydrogen-producing bugs. You'll see a spike in the ileum. And then when you get to the colon and back to the normal flora, you generally see another spike. Now, it's really tricky, though, as we'll allude to later. So some more information. The CPT code is above so that you want to have people check. And then for the home test, you want to make sure that you're clearly going over the instructions and making sure that there's no false positives or false negatives based on not following the instructions. So this is going to be a little bit of, going through this may be a little bit difficult for us to kind of truly get on the first time through, but I'll do my best. So this is talking about the limitations of these tests. So one thing, like I said, with lactose, lactulose breath test, it does cover methanogens and hydrogen producers, but what they have found is that sometimes it's showing spikes. It's showing spikes further into the intestine based on motility. So if someone has rapid motility just normally, then it may show that the patient is it may be a false positive. There's actually no bacteria there. Now they're doing tests with scintigraphy where they've actually had people do the lactulose breath test, and then they have radioactive dye traveling down, and they're seeing in a lot of these patients, they actually don't have SIBO. They have, it's just the solution is reaching the cecum, which is the part of the colon, and there's actually no bacterial overgrowth. So it's a little bit in question. Now, hydrogen is absorbed further up in the intestine, so we don't really see that problem. Now, hydrogen does not cover methanogens. So these are things to be considering about when you take your select your test. These are some of the limitations. One thing I would say about methane, because it's generally associated with constipation, I've had people that seem like they're just a sort of sure bet for SIBO go in, and they come back with completely normal SIBO breath tests, a lactose breath test. And some of digging through the literature, it does point out that someone's intestinal transit time may be 5 hours, and these tests generally last 3 hours. So by the time they're getting into bacteria that might be in the small intestine, the test is over. So just weigh that in as they learn to improve these tests. So Dr. Pimentel has criteria that has not been validated, but it presumes that the mouth to cecum transmit time is always greater than 90 minutes, meaning that a peak in breath hydrogen within 90 minutes of lactulose ingestion must be due to bacterial fermentation in the small bowel. However, this particular study shows that this is population specific. Various subpopulations will have different transit times, and so it's not necessarily 100% reliable that it takes that after ingesting it at 90 minutes will still be in the small intestine. And this will make sense when I point out some diagrams. So this is what you get back on the lactulose breath test. You can see this peak on this graph is of hydrogen production, and this peak needs to rise 20 points above the baseline to say that there's overgrowth. And so, and it has to be, like we said, has to be within 90 minutes. So in this particular patient, we see a peak you see this rise, and at 60 minutes it started to increase, and there was substantial hydrogen production. So the same thing, the bottom line is the methane production. So in this patient, they had no methane production to note. Okay. Hang on 1 second, just. Throwing off just a tad here. I'll be right back with you. Okay. All right, so here's another common feature on lactulose breath testing. You'll see this bimodal peak, and this is indicative of, in this particular test, hydrogen producing overgrowth in the small intestine. It does fall that this peak happened fairly early, so it started climbing at the 40-minute mark. So this is sort of a reliable indication of bacterial overgrowth. And there's various guidelines, and I'm going to consolidate the guidelines here in a second. Okay, sometimes you'll get these reports back from various labs that give you their impression. And one of the things that comes up a lot is fasting elevation. Now this is tricky, so sometimes the patient will follow directions and their baseline is quite elevated. So some of the thoughts are that if the methane and hydrogen are elevated at baseline, it may be secondary to residual colon or bacterial overgrowth. So the thinking is that sometimes there might be fiber in the colon causing this, or impaction. So you sort of have to make a judgment call. Someone asked me, do you just stop the test? I don't think you stop the test. You want to see the whole thing through and see the patterns, and make an assessment whether this is bacterial overgrowth or was contamination from the oral mucosa, or if the patient, truly this was a scenario where we were seeing bacterial overgrowth. Again, I'm pointing to some of the looseness of these guidelines. And this is a methane positive patient, and you can see that there's the bimodal wave. This patient's probably a constipated patient. And this just is a study that shows the likelihood of a methane producer being an IBS-C patient is 3.6 more likely, and more of a systematic review proving the same thing. So here's some problems. There's a lot of false positives and false negatives with this test, and generally I'd say what I've seen is that it's 60 to 70% sensitive, and but it is more specific than that. It's I've seen between 70 and 80% specificity. The data jumps all over the place in the research, but if it matches clinically, then I think it's a good tool. This is a meta-analysis of breath testing and its correlation in IBS. So this is sort of a consolidation of my take on all the ups and downs of the research. First, consider using the glucose hydrogen test in diarrhea subtypes, and consider lactulose in mixed constipated subtypes so that you can pick up methane. And if the hydrogen peak exceeds 12.2 ppm when the baseline is 10 ppm, then consider it a positive result. But I would say just make sure this happens before 90 minutes. The double peak appearance is really generally a good tool to see, and one early peak seems to be clearly that there's some fermentation going into the small intestine. Our merged peak before 90 minutes, again, is a judgment call. Sometimes you'll see this one peak, but if the peak rises fairly early, I think it's indicative that there's some growth going on higher in the intestine, especially if it's exceeding baseline by 12 ppm. And unfortunately, the best way to know if you're right is to treat and see if our patients get better. And then remember, with baseline elevation, you should weigh that for bacterial overgrowth, especially if someone is having methane elevation at baseline. So treatment. So this is the way that the Cedars-Sinai approaches SIBO. It's driven by Lactulose breath test. Their principle, we'll sort of go into this further, but their principle is to treat with antibiotics first, and they use rifaximin first, and then they do generally 1,200 milligrams daily for 10 days, and then they do a repeat test, and if it's abnormal, they generally repeat this, maybe with the same medication or neomycin, which is another antibiotic choice. And then if the breath test is normal and the patient is clinically better, then they go to prevention with nighttime low-dose erythromycin and then low FODMAP kind of diet. If the patient's not better, after this sort of breath test being normal, they figure they were treating the wrong thing. So that's kind of the core of what they do, and they do, they tend to get people better fairly well with this protocol, and the only concern is the reoccurrence rate, and that's what I'm trying to work on with my protocols is can we set something up that sort of takes care of this and manages it and prevents it from coming back. So this is, one thing I would also say is on last resort they use something called Vivanex, which is the elemental diet, which is sort of a highly absorbable nutrition source that will not feed, will not generally sort of cause fermentation. So this is interesting. This study looked at in functional bowel disorders, which SIBO would fall under. It looked at what would be sort of the least invasive but highly effective therapies, and it seemed like the Fodmap diet fell kind of in that category. It was on the low invasiveness and effectiveness with treating these microbiota functional issues, and stopping proton pump inhibitors seems to has good data behind it. Exclusion diets, probiotics, and then pro-motility agents as well. I'm not sure about prebiotics. I don't know how that generally would work in SIBO, and probiotics as well. There's some data, but it's really weak. So this was an interesting take. There's more data on probiotics in IBS, of course, and this is probably generally referring to IBS versus referring to SIBO. So I don't want you to get confused that this is a SIBO-specific study, but it gives us some framework to think about. Okay, so this is a meta-analysis on antibiotic therapy for small intestinal bacterial overgrowth. They looked at rifaximin, they looked at neomycin, flagyl, ciprofloxacin, they looked at tetracycline, and so for statistical incident, significant studies, rifaximin seems to win out. And interesting enough, in one of the studies, rifaximin used, this is obviously a big meta-analysis, but the rifaximin 600 milligrams per day for 7 days, plus guar gum seemed to cure 85% of the subjects, which is really counterintuitive. But guar gum is not a high FODMAP fiber, so this was. But and what's also interesting is it's not really been repeated very often. But that was, and rifaximin is something that really became popular through Cedars-Sinai's protocols. The neomycin data is weak, and the only really good data is rifaximin. Now, interesting enough is I think rifaximin really shows up working really well for the diarrhea type subjects with SIBO, patients with SIBO, but it doesn't generally have a lot of data in constipation types, even though there is some data that it will lower methane. So we have this kind of what to do when we have a constipated patient question. And I just talked about all this. Also interesting enough, ciprofloxacin had 100% normalization of the breath test at 500 milligrams twice a day for 10 days, but there was only 14 patients in that study. So again, I already talked about this. Methane producer subtypes were not generally covered by this, and there isn't a lot of data. What I've seen, what most people do in the literature is they combine neomycin with rifaximin in methane types. I did see a sort of preclinical, well, a small trial I did see with Alinea working to reduce methane. I did come across that in my research, so I'll be interested to see that, and I think that makes a lot of sense to me. So Dr. Pimentel is now involved with a study of neomycin plus rifaximin and then neomycin alone for methane-positive subjects with constipation and IBS. I did correspond with him. He said it's waiting to be published, so we're just kind of waiting to see what comes out of this study. But just more about methane. Here's a slide about the cost of antibiotics associated with treatment. Rifaximin is quite expensive. One thing I want to point out is only 0.4% of rifaximin is absorbed by the gut. Most of it stays in the gut. Neomycin, 5%. There is some reports of ototoxicity in neomycin that you want to read up on. Neomycin is really dirt cheap. It's all these things would weigh in. We tend to do more for our patients than the Cedars-Sinai protocol, so I don't even know if we need to necessarily use antibiotics in our approaches, and I certainly don't use them in all patients. So the big issue with prevention of recurrence, there is some data that erythromycin being used after this eradication can prevent recurrence. It seemed to reduced reoccurrence to 138.5 days versus 59.7 days without the erythromycin. But erythromycin in this setting is a promotility agent, so it also seems to tonify or balance out the migrating motor complex. One thing that is being touted now is, since sometimes you put patients on this and you ask them if it's really helping and they just say, I don't know, and they're not getting much response from it. So Vanderhoof suggests doing sort of a more therapeutic trial of a higher dose of erythromycin just for 2 weeks, just to see if that helps and is more noticeable before converting to the 50 milligram, just as a proof that that the migrating motor complex is an issue and that improving motility may help. I think this is a reasonable strategy. Probiotics for SIBO have not necessarily just been done specifically for SIBO, most are for IBS. The ones that have been done aren't really that convincing, except in children. There is one listed here that was done for children with short bowel syndrome. And so most of these are Lactobacillus and Bifidobacterium. And I do think, and they're sort of poorly designed studies. I went through most of these, and I think there's great studies being done on IBS, and I think we have to sort of extrapolate. Are we treating IBS? Are we treating SIBO? Are they a separate issue? Are they the same? And make a decision. But I do think we have to be cautious about what's in the probiotics and when to use them. Maybe think about if there's still bloating present. Would you want to make sure there's no prebiotic in the probiotic you're giving? Anything that may cause more bloating. But I generally feel like they do have a place, and I'm seeing more and more that I'm using probiotics in the earlier stages of treatment, not only just for secondary prevention, but also actually for motility. So I can't back it up with studies. I can just say clinically I see there's some benefit using probiotics with SIBO. This is a really good paper by Quigley, and again he's sort of backed up what I was talking about. Most of the data that's done with probiotics in this setting is with VSL number 3, which is sort of a pharmaceutical grade probiotic. Quigley talks about how he thinks that probiotics may be preventing translocation of the bacteria from the gut to other areas of the body, and there's sort of his comments are that we really need to take more of an in-depth look here and see how we can use probiotics to balance the gut and prevent SIBO. He also suggests that with chronic diarrhea, Lactobacillus casei and Lactobacillus acidophilus were effective. I think those are in VSL number 3. So other natural treatments, the big one that we'll talk about in a second is the low Fodmap diet. It's considered a primary dietary strategy for IBS, and also appropriate for SIBO. Maybe, theoretically, it makes a lot of sense that SIBO would be responsive to a low Fodmap diet if the patient has diarrhea. We'll see later that it's actually sort of not really theoretically matches up that it would help with constipation, but clinically it seems to be helping with both. Other dietary strategies are listed. Gluten-free, casein-free diet. The SCD diet is really popular for treating SIBO. GAPS is really popular. I think you have to be comfortable with what you think makes sense given the framework of your understanding, and also what you feel like your patient will be compliant to. If they have no means or no motivation to do these diets, it could cause more stress, more problems. So it's sort of a individual basis. Peppermint oil is also been shown to improve hydrogen breath tests in a case report. Anecdotally, I would say that enteric-coated peppermint oil, bitters, iberogast, activated charcoal, all will help palliative for various things that come up during SIBO treatment and occasional flares. Low FODMAP diet, I had a presentation on this in itself, so it's really a really in-depth topic. It's being used for irritable bowel syndrome, being researched out of Monash University in Australia. It's being used for Crohn's disease and sort of overlapping into the SIBO world and various functional bowel disorders, one of the more researched diets in this capacity. And these are the main researchers involved. FODMAPs are listed here. They are poorly absorbed simple carbohydrates, basically, that require a lot of help to get across the gut, and so they hang around the lumen quite a bit and cause fermentation. And in some people, there's no intolerance to them, and you can eat plenty of them. And other people who have more issues with enzyme processes on the gut lining will have problems digesting the FODMAPs, and will also have issues with fermentation of the FODMAPs, especially in the setting of SIBO, because they're rapidly fermentable carbohydrate chains. So these are the applications I just talked about. And this just tells you more about what their components are. So they're not starches or polysaccharides. They're short chains, and they're very osmotic and rapidly fermentable. This shows you where FODMAPs are absorbed. So sucrose, which is sugar, basically the basics of sugar, is in the proximal small intestine, and then as we go down, you can see fructose, lactose, and the polyols are all digested in the small intestine, and then the fructans and the galactans generally aren't really absorbed by the body. So this is something you can go through. It just tells you, this is a subject in its own, what foods are high in fructans and galactans, and as you can see, inulin, so FOS, is something that's considered a prebiotic, which feeds bacteria, and that's in this group. And lactose we're all familiar with. Polyols are used in a lot of sweeteners and additives, and in some fruits, some vegetables. So I'm going to go through why we think food is a choice to help with this problem. So essentially, what we saw earlier is this setting. We talked about how food interacts with the microbiome in the lumen. So if there's bacteria there, it's going to cause various changes in the intestinal wall, leading to potential inflammation, motility disruption, changes in the epithelium, and ultimately this kind of setting of visceral hypersensitivity, dysmotility. So it sounds a lot like what happens maybe if food is a cause to IBS, but this is definitely, I think, this is a model that's just used for all functional gastrointestinal problems, but I think it does generally apply for our framework of what's happening with SIBO, and we've already kind of covered this. So this is the this review by Gibson and Shepard out of Monash University. They did look at small intestinal bacterial overgrowth, and they did see that that there is some issue with fructose absorption and its correlation with small intestinal bacterial overgrowth, and that the FODMAPs seem to be either associated or a contributing factor. This was the first I've seen that it's overlapped. Now they do the breath hydrogen test in their studies, so I think they are applying bacterial overgrowth in a way that we can use to see if FODMAPs are contributing to hydrogen production. And there is some sense that there's methane, they can measure methane production through this. This is, again, talks about some of the physiologic effects of high FODMAPs, how they contribute to bacterial fermentation, how they can change motility. But they are useful because they're prebiotics. So we have to be careful with this is we don't want to be anti-FODMAP. We just want to use it when appropriate and heal the gut and get people back onto a healthy diet. And we want to be smart about it and find out maybe they're only having intolerance to 1 or 2 FODMAPs. They're fine with lactose, but they have a problem with fructose, or they have problems with the galactans. So it's a methodical process that we go through. This is a really excellent slide about how down in Monash they treat functional bowel disorders. They breath test everybody, and so they do qualify that the patient will be willing to make dietary changes before they even start talking. And they test for lactulose, fructose, and lactose. So they're getting some sense of overgrowth or any intolerance to some of the FODMAPs before they even start. And then they go on a restriction FODMAP diet depending on the results. And they do monitor through diaries and symptom questioning. If the patient doesn't improve in 6 to 8 weeks, they consider other allergens or other triggers like gluten and food chemicals. If they have partial improvement, they consider adding on, so doing FODMAP plus gluten, or FODMAP plus salicylates. They are FODMAP plus histamine food, so they kind of refine it. And if there's satisfactory improvement and doing well, then they move to a re-challenge of these FODMAPs and figure out which of them that there's a true intolerance to, or if they've resolved the intolerance. It's a very well thought through process, and I think using this as a guide would be helpful in treating SIBO. So this is kind of my approach, and it's based on what I learned from Dr. Galland with the 4R approach that's made has all different kinds of versions, but this is sort of, a lot of people want to know how to treat this naturally, and this is what I generally do. This is the first step, and I'll take you through these various steps. So this is my flow sheet on step 1. I use, and this is obviously evolving, but here's what I would do today. Baseline, if I've made a SIBO diagnosis, I use something called a Digestive Wellness Questionnaire, and I get a baseline. This is something that's put up by Integrative Therapeutics. It's really helpful. And then if a patient is cybomethogen positive, and they're constipated or bloated, or have diarrhea and bloating, I'll go down different tracks. So I will talk with the patient. With constipated, I'm leaning more towards a paleo diet because I feel like there's a little bit more chance for fiber to help with constipation, and just a little bit more flexibility, especially if there's sort of anxiety around it, and also it just makes more sense to me that it would help with constipation and also reduce fermentation. So it takes out gluten, dairy, sugar, soy, is the primary things, and then sort of questionable about legumes, and it really minimizes fruit, but really loads up on the veggies, and you can have other grains that are good sources of soluble fiber. And then if it's diarrhea, then I will definitely look at the low FODMAP diet. Along with that, at the same time, I do antibiotics or plant-based antimicrobial protocols, which I'll go through, to eradicate bacteria. So this is removing the triggers. And then the red, yellow, green. So after the so with a plant-based approach, I take 4 weeks to reassess. With the antibiotics, generally 2 weeks. So if there's no improvement, I sort of reassess that I'm on the right track, or we're on the right track. If it's yellow, meaning mild improvement or moderate improvement, then proceed to caution, or sometimes we'll consider retesting to see if we're still dealing with SIBO. If it's strong response, I'll move to the next stage. So this is sort of summarizes phase 1. These are some of the specific things I'll use, but you can, consider your own choices here. This is just what works for me. And biofilm chelation I sometimes add into the mix because I might suspect a candida comorbidity, and I feel like a biofilm chelation is important with addressing candida, and so I might add Interface Plus in by Claire Labs to help with eradication during this phase. These are some of the plant-based antimicrobials I've used and have seen work. Biocidin is sort of my top choice right now. Undecin I've used by Thorne, Parabiotic Plus. I have no affiliation with anybody on this stuff. It's just sharing. So, just one thing I wanted to point out. This is by Kate Scarlatta. She made this up for me, and it's really, and by the way, she has several books on SIBO that are really good and user-friendly. Actually, one book I know for sure, and I think she has some other books on IBS and digestion. So this is a half plate of fiber. That's really important that veggies and fruit make up half the plate in the FODMAP. Otherwise, I worry if we're going to be pushing constipation, even though these are low FODMAP fiber sources, so they shouldn't cause fermentation. And the size portions are really important with with FODMAP. So when you learn how to teach FODMAP, you have to really learn the sizes of the portions, because if you eat too much of a low FODMAP food, it can sort of add up and become sort of a high FODMAP scenario. So now we'll move on to phase 2. So if we're on phase 2, then the goal of this is to reestablish natural digestive processes. So restoring the pH of the intestinal tract and restoring the migrating motor complex. This is usually a 2-week process. I have the patients continuing on the low FODMAP diet, and then eventually move them through to phase 2B, which is part of this, again, establishing the innate processes. So I'm supporting GALT and re-inoculating the gut flora. So this is when I do things to help raise secretory IgA and re-inoculate the gut flora. One of my favorite new products for this is Probiomax Plus by Zymogen. It's very SIBO friendly, and it has immunoglobulins in it, and also it has a good, nice blend of probiotics. It has galactin in it, so it sort of is an all-in-one for me with this phase. This is my biocidin protocol I use for the plant eradication. They're usually on this for at least 4 weeks. Sometimes we have to keep repeating the process, but it's gradual buildup of the biocidin capsules. I'll show you what's in those in a second. And it increases week by week. Also, interface will be added in as needed. Occasionally, if there's sort of a constipation issue, I will use a probiotic at bedtime as a prokinetic if I'm not using erythromycin. So this is biocidin. Here's what's in it. It's broad spectrum covering yeast, bacteria, parasitic, microbiota. One of the concerns is, does it kill off some of the good stuff? We will always want to be concerned about that, and that's why we don't stay on this forever. We're just trying to get to a clinically stable position. And bloating, like I said, is sort of the key, is following that, and then bowel function. So here's phase 2A. Like I said, we're reestablishing natural digestive process. We're continuing with nutrition plan, and then we're also restoring the intestinal tract with a betaine HCl blend to tolerance, and then we're going to also work on eating hygiene habits and stress reduction, and work on restoring the migrating motor complex. Now, interesting enough, besides what I talked about with probiotics, 5-HTP and melatonin sort of anecdotally at bedtime have been known to help restore the migrating motor complex. I haven't seen that work a whole lot in my practice, but I know a lot of our docs talk about that. I'm going to be wrapping up here fairly soon, so hang with me and we'll get through this. The phase 2B is, like we talked about, after 2 weeks of doing really good on 2A, I moved to this, and this is further reestablishing the gut health. We're continuing doing more of the same that we did in 2A, but now we're adding the probiotic Max Plus, so re-inoculating, replenishing secretory IgA, and the gut immunity. Now you can notice that I do check with a baseline for the digestive wellness questionnaire, and I just sort of use that, and are we on track, are we doing well, or do we need to sort of think that if we're really helping the situation. Then we move to phase 3. Once we're stable there, if we're getting a good response, phase 3 is gut repair and increasing the gut wall integrity. I tend to use something called PermaClear by Thorne because it has sort of all these nice gut healing agents, and fish oil for inflammation, just to improve gut wall integrity. And we just sort of maintain this for about 6 months if everything's going well. If the diet that they're on is causing problems and they feel ready to challenge it, we might at that point challenge it. But it would be generally good to stay with a low FODMAP or whatever dietary approach is for 6 months before challenging. You just want to ensure stability because there is such a high rate of relapse. So this is just what I just talked about. It's sort of another visual. You're continuing the supplements, and then eventually during this phase with stability, I also will have them discontinue the erythromycin and the betaine HCl, and especially if the betaine HCl starts to reduce. So as you take more of that, it should start to build up, and the hydrochloric acid should start to stabilize, and the supplement would start giving the patient symptoms of burning in their chest, and so or kind of burning sensation with food. So we start to reduce that and come off that as soon as possible. So it's really important to have secondary prevention, and this is all what we've been trying and aiming for to accomplish. So basically we've covered a lot today: evaluation, clinical findings, proper selection of workup, careful monitoring of pattern shifts throughout the treatment, such as bloating and the digestive wellness questionnaire, and making sure that we're on track at various checkpoints. And there's a few typos here. I apologize for that. So, and what we're trying to do with this approach is to really heal the gut. And hopefully, I can't say for sure because I've seen it work really well, but we don't have the studies that they have to prove that this is the way to treat SIBO. But I feel like it's more holistic. It's a really holistic approach and covers the innate process of the gut. And this sort of flow is a very responsible way to approach SIBO, so you're not missing anything else, and you're making sure that you're treating the right condition. So again, these are the central issues we talked about, and I think when we do treat this and we do turn this around for patients, it's quite remarkable as a quality of life improvement, and hopefully it will make a long-term impact on health. We do need to be cautious of what we're doing to the gut microbiome, and just make sure that we're not just assuming that that we're being judicious and we're not doing more than is necessary. So if anybody has any questions, they can email me. I will say that if you have any questions, you can post them. There's a few things that will be in the slide about some of the studies being done with Parkinson's disease, fibromyalgia, and I'll have those when I email it to you. I want to just post one more thing. So for questions throughout today and tomorrow, I'd like for us all to kind of chat about existing questions or observations you've had. If you could post it to my Twitter, I think that would be good. If, so let's see here. Yeah, so at the bottom here, at Dr. Rindy on Twitter. You can sort of post questions, and I'll try to respond. And I don't profess to be an expert on this, but I have found that I just really enjoy thinking about this and all the interconnections, and learning from you and learning from my patients, and hopefully today was a step forward and filled in some blanks. And the next time, hopefully I do this, it'll be even better. And thank you for attending. I will be sort of refining this and putting some the references together, and hopefully emailing this recording off here in the next few days. Thank you so much for attending.